Dear audience, dear colleagues, and dear committee, let me introduce my PhD topic. The title is Investigation of Techniques and Materials in Vitopulp Therapy. Some words about myself. My name is Péter Komora. I'm a clinical specialist and a second-year PhD student at the Department of Restorative Dentistry and Endodontics. My vision is the minimal invasive endodontics, and my mission is to reduce the invasiveness in endodontics through evidence-based science. To fulfill my mission, I have two ongoing projects. Both of them are systematic review and meta-analysis. Some words about the first topic is the comparing the efficacy of bioactive materials in vitopulp therapy. It's a systematic review and network meta-analysis, and we started in 2022 in September. Some words about the background. The root canal treatment is an invasive treatment option to result in loss of tooth vitality. According to the literature, we could calculate with quite good success rate, but really important to emphasize that the failed root canal treatment could end up in tooth loss. The vitopulp therapy treatments aim to preserve the pulp vitality in order to avoid the root canal treatment. The MTA, the mineral trioxide aggregate, is the gold standard material for the vitopulp therapy treatments. But in the last 10-15 years, a lot of new bioactive materials came to the market with less drawbacks to MTA. These are easier to handle in the clinical application, and they are lower cost alternatives to MTA. So therefore, our aim is to compare the bioactive materials in vitopulp therapy. Our clinical question was, is there a difference in efficacy of different bioactive materials to MTA in vitopulp therapy in permanent teeth? We used the PICO framework. Our population is the permanent teeth with vitopulp therapy treatment. The comparator and the investigation group are similar because it's a network meta-analysis, and our outcome is the failure rate of the vitopulp therapy treatment. It means that the patient has any clinical signs, symptoms, pain, or maybe we could find some problem at the periapical part on an X-ray. And our hypothesis is that the new bioactive materials are at least efficient in preserving pulp vitality than the MTA. So we conducted our systematic search in 4 different databases, but after the rejection of the first draft, we made a new search in this year at the end of January. And after the plus mark, you could see the new articles. After the flowchart of the selection, we had 21 eligible articles. So we have 7 new articles, and we have some new data. And it helps us to make 10 different subgroups. But because of the short time, I would like to show you just 3 subgroups. These are the failure rates of vitopulp therapy treatment after 6 months, 12 months, and 24 months in the subgroup where all treatment modalities are together. On the slide, you could see the outcome forest plot and the network plot. First, I would like to show, and I would like to say some words about the network plots. Here, the orange circles represent the different materials which were compared, and the size of the orange circle represents the number of patients who were treated with this type of materials. The line between the materials represent the direct comparisons where real studies were made, and the number on the lines represent the number of studies and the number of articles. And on the outcome forest plot, you could see that all materials are compared to the gold standard MTA, and the vertical line is the zero effect line. And if the point estimate the circle, if it's on the left side, these materials are performed better in a clinical application than the MTA. If the point estimate is on the other side, these materials are performed worse than the MTA. And of course, the line represents the confidence intervals, and if the line reaches the zero line, there is no significant result. After 6 months, you could see that we don't have significant result, except the calcium hydroxide, and the calcium hydroxide LC is the light curing version of the calcium hydroxide. And really important to emphasize in case of CEM is the calcium enriched material, that here we had really few direct comparisons, and we had really few studies on the network, but you could see that there was just one direct comparison with the calcium hydroxide and one direct comparison with the MTA. After 12 months, you could see that the results are changing a little bit. Here we have some more significant results in case of terracal LC, calcium hydroxide, and calcium hydroxide LC. And after 24 months, you could see that the MTA seems the best material after 24 months, and you could see that we have also some significant results. So the strength of our study is that we included just randomized clinical trials. We have a quite high sample size in every subgroup, and we use an integrated method for the success rate and the failure rate calculation, and it's a network meta-analysis. The limitation, not every arm is quite strong in the network, like in case of CEM, and there are comparisons with only one study or two studies. Our conclusion that the MTA is the most effective material for vital pulp therapy after 24 months. The biodentin and the total fill could be a suitable alternative to MTA in clinical application. Our implication for the practice that the biodentin and the total fill could be a good alternative in a clinical application. The 6 months follow-up is not enough to evaluate the success of the vital pulp therapy treatment, and we don't recommend the calcium hydroxide in clinical application anymore. Our implication for the research, the results of the clinical trials need to publish after 6, 12, and 24 months respectively. Of course, we need more randomized clinical trials to evaluate the efficacy of novel calcium silicate sealers, and the demographic data, for example, the age of the patient, the two types need also published. Some words about the manuscript. The first draft was submitted in the last year, October, then we get a rejection. After that, we made technically 80% of the selection we made again, and we had a lot of new data, and we made a new statistical analysis. And last Thursday, we get also a rejection, but on Friday, I submitted our work in another journal. The scientific report is the new target journal for us. Some words about the second project. It's comparing the root canal filling quality of calcium silicate-based sealer. It's also a systematic review and meta-analysis, but that will be a meta-analysis of in vitro studies. Some words also about the background. In particular, pulpal and periapical pothole is the only option to save a tooth is the root canal therapy. And it's an essential step in root canal therapy to maintain a well-sealed root canal system. The H+, it's an epoxy amine resin type material, is the gold standard material for sealing of the root canal system, but the root canal filling procedure is less complicated with new calcium silicate-based sealers and have some promising biological benefits. Therefore, our aim is to compare the different sealers in root canal fillings. Our clinical question, is there a difference in root canal filling quality of different calcium silicate-based sealers to AH+? Our population is the permanent mature extracted teeth and artificial teeth. Our intervention group is the calcium silicate-based sealers. The comparator is the AH+. And our outcome, we have primary outcomes, the percentage volumes of filling, voids, gaps, this related to the quality of the root canal filling. And we have some secondary outcome you could see on the slide. And our hypothesis that the root canal filling with the new calcium silicate-based sealer are at least efficient than with the AH+. We made a search key and we made a systematic search also in 4 different databases. On Monday, the Prospero is already submitted and the duplicate removal is also done, and now we are in the selection process. As an overview, you could see our 2 ongoing projects. And some words about the additional activities. We had TDK students, and I had a supervisor for some diploma work, and some conference presentation was in the previous years. And I would like to thank you for your attention with the quote of John F. Kennedy: "We choose to go to the moon in this decade and do the other things, not because they are easy, but because they are hard." And I would like to thank you for your attention.
Actually, you are the best candidate for this question because I know you as a endodontics expert, so you have plenty of clinical experience. So how your meta-analysis work modified your clinical practice or clinical thinking? So I think you are the best candidate today to tell this.
First of all, as we emphasized that we didn't recommend anymore the calcium hydroxide in clinical application, and for that we have robust evidence and mathematical evidence, and we could disseminate this information that we have to forget the calcium hydroxide, because in the literature we could find other articles, different trials which are trying to use the calcium hydroxide, but it's really important for us that we could say that the calcium hydroxide is not the best candidate for this type of therapy, for VitoPulp therapy, and really important that next to the MTA we have some other alternatives, and they are easier to handle in a clinical application, because the MTA is a quite good material, and after all results is the best material at this moment, so it doesn't change, but the clinical application is problematic. It's not so easy to handle, not so easy to apply on an opened pulp chamber, and we get also some data about the biodentin or this total fair root repair material could be a good alternative, and these are easier handleable type of bioactive materials.
I was just wondering that, do you know the reason behind this, that why is the MTA is the best material? So what properties does it have that makes it the best?
Thank you for your question. I think I'm starting from the calcium hydroxide. Why the calcium hydroxide doesn't work? So first of all, in case of calcium hydroxide, there will be just a mineralized barrier above the pulp tissue. But in case of MTA or biodentin or total fill, it was proven in vitro studies and in histological studies that there is a real dentin formation. So it's a reparative dentin, so it's like the tertiary dentin, but there is a really hard tissue formation, and it's one of the key elements why these materials are working better. And of course, they have some biological aspects, and they could improve the regeneration potential of the pulp tissue as well. So I think these two are the main or the key element why these bioactive materials are working better in a clinical application than the calcium hydroxide.
Congratulations for your progress. My first question is that for calcium hydroxide, as I saw, is not recommended. Is this difference whether it was traumatic, for example, for anterior teeth pulp exposure, than like pathologic? I recently saw some webinar of Pascal Mania said like the calcium hydroxide with I don't know how many years of follow-up. So does that has a difference maybe?
I think after our results and this mathematical evidence shows that the MTA or the biodentin is better in this application as well. So
regardless of the cause of exposure.
Regardless of the exposure, because we had, as I mentioned previously, we had some subgrouping according to the different treatment modalities, like direct pulp capping, or pulpotomy, or partial pulpotomy. And for example, in case of direct pulp capping, the MTA, the biodentin, and the total fill is performed similarly. And the calcium hydroxide perform also quite worse in these scenarios as well. And the direct pulp capping is, how can I explain? It's the least invasive vital pulp therapy treatment, because there we don't have to make any preparation in the pulp tissue. In the other treatments or treatment modalities, we have to remove a part of the pulp tissue or the whole pulp tissue from the pulp chamber. So according to these results, if it doesn't work in a least invasive type, we can conclude that in more severe or more invasive cases, it's also not the best option to choose.
Well, my second question about the second project, like, does the sealer type have a value? Like, if we use the thermal technique of obturation, like System B or thermal obturation, for filling gaps and voids?
First of all, we have to say how many Full-text articles we have, and at the beginning, we doesn't want to mix with the filling techniques. So at this moment, our aim is just saying the materials. How does these materials perform, and how is the root canal filling quality? So how many gaps we have next to the filling material, and how many gaps are inside the root canal filling sealers, and next to the canal walls and the sealers. That's the main goal. But of course, if we have more data about the different filling techniques, maybe according to the filling techniques, there could be a possibility to make some subgrouping, or maybe analyze the different filling techniques with the different sealer types. But at this moment, I cannot say more about this topic. So at this moment, we are focusing just on the quality of the root canal filling.
Péter, I still would like to ask you, you showed here that one of your papers was rejected. From which journal was that?
The first rejection was from the International Endodontic Journal, and the second rejection was also from the International Endodontic Journal, because after the first rejection, we get a lot of comments from the reviewer, and we had to rethink our selection and our statistical analysis as well. And we collected a lot of good ideas from the reviewers, and we made it. But as I mentioned, technically, almost the whole project has to be redo from the selection process as well.
Yeah, actually, because that journal is a hard stuff, so it's not so easy to publish here. What was their main concern? So what was the problem with your work?
After the first rejection, we get some comments about the methodology, and after then we redo it. And after one of the reviewer suggests that they thought that there is not enough new data, and the network meta-analysis doesn't give enough new data to publish it in their journal. That was the main, and because of that, we don't have option or resubmission in the same article. In the same journal, sorry. And therefore was the reason why we are going further.
Okay, so this is Center of Translational Medicine, and then we expect actually our colleagues to send the paper in top journals. It goes through directly in about 20%. It has a very major review in another 30%, and then about 50% the first journal rejected. And we are proud of that, actually, I have to say. I mean, so do this at this level, I mean, you have to be ready for this, even if the work is very good, and we saw in many cases. But that's already actually quite positive that they took actually the work on that, so they do the review, because some journals, I mean, some top journals, I mean, just send it back, and then they say. So this is a part of the business, I have to say, that if you try to do this. But if you put into account, I mean, actually, the previous year, I mean, that who are now at year 3, I mean, they went through on these 2, and then virtually everybody has an accepted paper at least in a Q1 journal, but 50% of them is D1. So that's the point, that we have to live with this. And we are very proud of this work anyway. Thank you.
May I have one question? Just it seems that good old calcium hydroxide is going into the drawer now. Is there still the application for temporary root canal filling there and periapical healing process?
Yes, of course. In this scenario, we could use it. And as a disinfection material for the root canal system, it's working good. But in vitro pulp therapy application, nowadays we have better materials, and therefore we recommend it. And nowadays the price is not so high, so we could make it with MTA, and they are working better after our results.
One more question. Just I noticed that the calcium hydroxide treatment with the light cure version even worse.
Yes.
Is that due because you are using the light source there, so you are actually destroying more the pulp because of the light, or because of the chemical components of the...
I think the chemical components, because the light curing type of calcium hydroxide contains resin, and it's a hydrophilic material, or it's a hydrophobic compartment, and it has some cytotoxicity. So I think that's the reason why the light curing version works not so well than the good old calcium hydroxide. So that's the reason behind it.
Sorry, like for... I'm so sorry. Okay, just one question. Like for MTA usage, does it influence the color of the tooth after a period? Like causes discoloration or not?
Yes, it's one drawback of the MTA. But there are some newer type of MTAs where the discoloration is not so big issue, but it's also an issue. So, and in case of biodentine, according to the literature, we found less discoloration. So that's another option, and that's another reason why we could recommend the biodentine for a clinical application as well.
Thank you.
Thank you for your presentation. I just have a technical question. Why do you approach your question from failure rate and not from success rate?
When we changed, honestly, after the first rejection.
Okay, that's fair.
because one reviewer has some smell to the statistics, and that was a real issue, and we changed for the failure rates. But of course, nobody wants to publish the failure, because we like to speak about success, and we like much better to publish our successful cases and about the success. But technically, it's the failure rate what we measured, and it's a proper name for the outcome.
Okay, thank you. Maybe it was just me, but because of the approach from the failure rate, I was kind of confused by the forest plots. Do we have to imagine a minus sign before of your results there, or not?
Mm-hmm. But on the forest plot, it means that in case of calcium hydroxide, we have 2 or 3 times higher chance for a failure. So and it's easier to understand for the audience as well, or the reader as well, who will read it, because in a clinical application, it doesn't matter that 10 patients are coming back with the toothache, or 30 patients is coming back. So in this case, it's a good way to interpret for a clinical dentist or clinical endodontist, okay, because they will understand what does it mean.